My name is Khalil.
Admittedly.
And welcome, Dr. Richard Ma. Dr. Richard Ma is Distinguished Professor of Orthopedic Surgery, Chief Division of Sports Medicine, Missouri Orthopedic Institute. So Dr. Ma, would you like to present at this moment?
Oh, sure. I mean, how's everybody doing this evening?
Wonderful.
Doing okay? All right. Hopefully, I think somebody give me a thumbs up here. So like, hopefully the video comes through. All right. So am I able to share my screen and stuff? Is that how this is going to work?
Yep.
Okay. Give me a second here. So I don't think I've met all of you guys. For those of you guys that don't know me, actually, me and Dr. Lopez go back quite a bit. I got to know Dr. Lopez when I was a fellow at the Hospital for Special Surgery, which is kind of where all you guys are kind of located out in the, except some. I know some is kind of closer to me here. But that's how Dr. Lopez and I know each other. When I was a fellow, I spent 2 years in New York, and I worked with Dr. Lopez in terms of research. And now I'm out in the heartland, in the middle part of this country. I don't know how many people have actually been to Missouri. I had never been to Missouri before I took but now this is my now my 7th year here. And I'm one of the sports medicine orthopedic surgeons here. And then I'm also a team physician for the Mizzou Tigers. And so, because I'm a sports medicine orthopedic surgeon, I wanted to kind of talk to you guys a little bit today about a research interest of mine, which is on ACL injuries. And so, hopefully, I wanted this to be kind of informal on some level. So, you guys are welcome to just kind of stop me while I talk about this. But I think one of the interests I've had is gender disparity. Particularly musculoskeletal issues. And I think that's really underappreciated, especially in the field of orthopedics. I think we're starting to kind of know that just because if I do a surgery in a young active male, their outcomes probably are not going to be the same as a young active female. And we all know, whether it be through personal experiences or some medical knowledge, that there are likely differences based on sex. And so I wanted to kind of talk about in one area where there are very clear sex differences in terms of outcomes that we can expect from a male athlete versus a female athlete, even when it comes to rugby. And so most of you guys are spending the summer learning about rugby science, injuries related to rugby, and I think this will tie in fairly well with the things that you learn, because this is definitely the case as it pertains to female, when you think about female rugby athletes in the return to sport. A lot of the evidence I'm going to present here is coming out of Australia. And so in Australia, you have Australian rugby and football league. And so that accounts for a large number of their ACL injuries in terms of females. And so we'll go over some of those data. So it says here, I'm going to try to share the screen here. It says this will stop others sharing screens. So do I want to continue? I guess it's a yes. Okay, so here we go. Can everybody see the screen here? Hopefully it comes through.
Yep, we could see.
Okay. So, okay. So, in terms of my disclosures, that may be relevant for this study. I don't have any really financial or industry interests that would color what I'm about to talk to you guys about this evening. And so, just as a starting out, for those of you guys that may not know, there's a clear association between ACL injury risk based on sex. We all know that female athletes are at a greater risk for primary ACL injuries when compared to their male counterpart at the same age playing the same sport. And that risk, depending on what you read, can be anywhere between 2 to 8 times more. So we're not talking about small differences. These are big differences. In a recent meta-analysis that was done, just looking at synthesizing the literature for various sports, found anywhere between a twofold risk, which is what rugby is, to a fourfold risk between female athletes playing the same sport when compared to their male counterpart in terms of risk of ACL injuries. And we see this a lot. And this was just recently in the New York Times, where people have started to notice that a lot of young girls are having these ACL injuries, maybe out of proportion to what we would expect when we consider a sport. And we also know, just looking at people that have had surgeries, that there may be an increased risk, particularly when it comes to girls re-rupturing that ligament compared to their male counterpart, which is what I'm showing here on this bottom right graph. And anywhere between 1.5 to a fourfold risk. So this is the background that we have when we think about females and ACL injuries. And the question is why? Is this true? And then hopefully this evening we'll kind of go through some of the evidence and maybe give a little bit insight why that may be the case. So before we get going too far, it is important to kind of just talk about some definition here. So sometimes we use gender and sex interchangeably, but reality, they mean two different things. Gender is a very socially defined thing. I could identify myself technically as gender female if I feel like socially that's what I am. So that goes with gender identity, expression, who I'm attracted to, and so those are things that are defined by me. But sex, when we talk about sex, that's your chromosome makeup. So so that is either XX or XY. There are mutations where people that have an extra copy of the sex chromosome, but just for the purpose of this talk, when I talk about sex, I'm talking about people that are biologically female. So that's a biological expression of what our chromosome says that we are, not necessarily who we identify ourselves we are. So that's the difference between gender and sex. And I'm going to focus on sex today, meaning the biological female versus male. And so these are my objectives. I'm hoping to talk about the rate of re-injuries following ACL reconstructions just based on sex in terms of what we know research-wise. And then I want to talk a little bit about not just how people, but not only just the re-injury rates, but how do these patients kind of feel? How would they rate themselves coming out of surgery after ACL surgery just based on sex? And then finish up maybe with some of the rationale why these differences may exist. So we'll go over this first part here. And when I talk about re-injury here, it is kind of important to make this distinction whether or not the re-injury is to the leg that they've had surgery on, or the leg that did not have the surgery. Because I think the evidence seems to point to suggest that there are differences between male and female, whether their risk is to the leg that they did not have surgery, which is the contralateral limb, or to the limb that they had surgery on, which is the ipsilateral limb, okay? So this is one of the original works that I saw that was fairly good. It's a prospective work, and this was done by Dr. Hewitt, who's up in the Mayo Clinic. He's very interested in this sex disparity, meaning the female risk of re-injury. And this work initially is a prospective work just looking over at about 102 athletes. And 63 of these athletes are people that have had their first time ACL surgery. And then he had 39 healthy control people who just never have had any sort of ACL surgeries at all. And if you look at what he found, he's basically only interested in individuals that have had non-contact injuries. So these aren't people that have had a tackle to their leg. These are things that happen, whether it be in the act of trying to avoid a collision, or they could have had a collision to another body part, but really no direct contact. That's how they describe non-contact in that study. And all of these patients have underwent rigorous rehabilitation, was actually cleared by their doctor for the ones that have had surgery to go back to sport. If you look at this bar graph on the this table here on the right, basically in that series, if you've had an ACL surgery, your chance of having another ACL injury is 25.4% versus 2.6%, which were the individuals that never had an injury at all. So you can already see one of the risk of having an ACL injury is if you had a surgery already. But when he dug into it a little deeper, you break it down between males and female, you see a relative risk of having a re-injury of an ACL of some sort being fourfold higher in females when compared to males. Now, when he looked at it in his series, and these are non-contact injuries, 12 of those injuries, so it was more likely in females when it occurred to happen on the other knee. So it's not the knee that they've had surgery on, but the knee that they did not have surgery on. And so, based on his description, he thought the female risk, even though they were more likely to have injuries, it's not necessarily to the leg that they've had surgery on, but it's to the contralateral leg. And this is a follow-up study of those patients. And so now they're carrying them out to 2 years with greater number of patients. And as you see on the graph here, females were 4.5 times more likely to have another ACL injury compared to just healthy females. And they're still higher, even though it's further out now at 2 years, 1.5 times more than their male counterpart to have another injury. And once again, it bears out that injury risk, even though it's now carried out 2 years, for girls, the injury is the greatest for the contralateral leg rather than the same leg that they've had surgery on. And so less number of people actually had, when they broke up just a percentage of people that have had the tears concerning both males and females, you can see that the breakdown is more likely to tear the other knee, which is 69.4% compared to 30.4%, which is actually the graph that they have placed. So when I counsel patients now, and I see them in surgery, the recovery, it is important to try and prevent injuries to the knee that you operated on. But we also are focusing on the other leg because I know just based on this history and these studies, the other leg is at greater risk, and more so for girls than it is for guys, okay? So what about just data looking at your chance of injuring the graft that you have placed? Now this is out of Australia, and so they matched 100 females to 100 males, and this is for 7 years. And these were all hamstring autografts. So for those of you that don't know the different kind of graft tissue you can use, usually for young people, they're gonna get tissue from somewhere to make it, so that's an autograft. And hamstrings are a very common graft. It's probably the most used graft in the world. The other ones that you may hear if it was your own tissue is patella tendon, and then quadricep tendon is kind of like the one that's newer, but maybe not as much information out about it versus the patella tendon. But in Australia, hamstring grafts are very popular. And so looking at this, they basically found that the girls who were that had these hamstring surgeries, they really didn't find increased rupture of the graft itself when they looked at males and females, just looking at the graft, meaning it didn't completely rupture at a higher rate compared to males. But what they did find was that girls had more likely chance of developing looseness in that graft. And so that's what you're seeing here. The Ligament test, the pivot shift test, and the KT test all measure some laxity of the knee when they examine the ACL. And so if you look at the Ligament test, which is, and then also the pivot test and the KT test, you'll see that the females had more inferior scores when it comes to Ligament and pivot, and higher KTs, which means it's looser on the machine when they stressed it, okay? So they didn't see increased re-rupture of the graft, but they did found that girls were more likely to loosen the graft more than the guys. Okay, and so this is another study looking at the same thing, looking at just hamstring grafts in men versus women in a different segment population. This is with just 1 year follow-up. And so same thing here, just looking at the Lachman grades, the pivot grades, with the female score all lined up on the left, you'll see a higher percentage among the females when compared to the males. In that study, because when they had 65 patients, you see the breakdown: 39 female, 26 males. They did not probably have enough numbers to prove this to be statistically significant. So they were all trends, but they were not statistically significant because I don't think they had enough power. But the other interesting thing that they showed was, if you look at the TEGNA score. So the TEGNA score is basically a questionnaire trying to measure your activity level before surgery, and then what you were able to achieve after surgery. If you look at the guys, their pre was 5.11, and their post is slightly higher than the pre. You look at the girls, they started out at a higher TEGNA score before their ACL surgery. But after their surgery, they never really got back to what they were before. And that was statistically significant. So the girls had a trend toward higher laxity, and their ability to get back to what they were before were less likely compared to their male counterpart, at least how they rate themselves on the activity scale. And these were for, once again, hamstring grafts.
Rich, could you go back? I'm sorry, could you comment on that? So you're telling me that maybe possibly due to the laxity in the females that they could not get back to their pre-TEGNA score?
Yeah,
Or...
I think it's hard to make that direct correlation. Right? But it's certainly something that is a possibility. So they just, for whatever reason, and then we're going to talk about some of the other things that it could not be. That may not be just graft laxity, because we're going to talk about some other factors,
sure,
like trust or fear. Those things are more likely to happen in girls. Those are obstacles that are more likely to happen for girl athletes than are for male athletes. So I think it's hard with this type of when you're looking at these in terms of looking at sex disparity, to just say it's one thing. I think there's probably a variety of things that may be the explanation why they may not do as well following ACL surgery compared to male counterparts. But at least in this paper, the things that they reported on, I mean, these are the things that they've reported on. But to make a direct correlation, it's hard sometimes with this. But this is what they've noted, and this is what we know, is that the girls may have looser grafts, especially when it comes with a hamstring graft, and then their activity level may not be as good as their male counterpart. Not be able to get back to what they were before compared to their male counterpart. And so, so that's what this study kind of suggested here. Okay.
Okay. Thank you.
And so looking at a larger set of study by older patients now. So as you get older, I think your chance of re-injuring your knee goes less, because at 27 years old, plus or minus 11, most of us are not in competitive athletics anymore. We have seasons. We're probably more likely recreational. And so that's part of the problem with this area of research, is that it's hard. We don't always have apple-to-apple comparison, meaning the ages of the patients aren't always the same. The surgery and the graft that they use are not always the same. And how we report the information is not always the same. And so then you get these heterogeneous, meaning different groups of people that you try to draw conclusions from, and they may come to different conclusions, but at the end of the day, the reason the conclusions are different is because the people that they're studying are different. And so that's saying there's no different when it comes to ACL surgery, is that you have to pay close attention to how old are these people, or what they were doing, what were they doing before, what graft did they use. And so in this particular cohort, the average age was 27, whereas the previous ones I've shown you was all in the teens when they've had this surgery. So they were less than 20. But nonetheless, like in this particular age group, there were some similarities that they did notice. One, men were more likely to injure the graft themselves. Women, when they had a higher risk, was more likely to the contralateral knee. So it was kind of interesting that they did bear that out even in the more older population. They did also bear out that women tend to have a lower activity level that they could achieve after ACL surgery. And so when you look at this here, the Mark's activity score, which is just another way to look at between the males and female, were less compared to the other side. And they also found that age was also a contributing factor on some level. Okay. So up to this point, we've looked at very, basically discrete patient populations, starting to kind of get bigger and bigger numbers. Like the Moon patient cohort is a pretty large number. Now we're going to try to clobber together a whole bunch of studies, try to see if we can get better, a better sense like what the literature really teaches us here. And so this is a systematic review, which basically is clobbering a whole bunch of publications, and then try to do a meta-analysis where we can try to, especially if they report things in a similar way, to try to get an idea, can we get maybe a large number of people? Like this is like 49,000 females, 70,000 males that've had ACL surgery. And so what they found in females versus male is that females tended to have more graft laxity. So that bears out in a larger population group. And that they're a slightly higher risk for need for revision surgery. They don't say exactly the reason why they needed to have another surgery. They can't, because different studies reported it differently, but that females are just more likely to need another surgery. But it was really because of so many groups kind of clobbered together, they really didn't separate out age, graft type, or how these people got injured. But they did note that female activity level after ACL surgeries were lower compared to the male counterpart based on the technical score. So this larger study bears out some of the findings from the earlier studies where it was a smaller patient population. And so in terms of like just looking at grafts and graft type, a lot about hamstring grafts here. What about looking at between patella tendon versus hamstring grafts when you look at males and females? This is the most recent study that came out looking at in young female athletes. So this is once again, so these are young girls who've had ACL surgery, and you look at, they described it between 15 and 20, which we think is like the highest risk group, and then 21 to 25. Usually once it gets above 20, the risk of graft re-tear or re-injury goes down because like I told you, these guys here, if you did a 15-year-old and ACL surgery, more than likely they're going to go back to competitive sports where they have seasons. They may be playing multiple sports. And what they found in this cohort of 256 females, they found that when you look at graft type, if you got a hamstring surgery when you're younger, in that age group, you're at a higher risk of having a re-tear to that graft compared to the patella tendon graft. And this did reach statistical significance. So this study suggests that the graft that you choose in the age group matters. So as you get older, rupture really was a relatively rare event, and didn't matter what graft that you chose at that point. Okay. So that's a single study. Now we're going to go back and look at it in a larger group. And so same thing here, looking at graft type. They did find that for males and versus female in the hamstring group, females are at a higher risk of rupture. Whereas if you use the BTB, which is a patella tendon graft, that didn't seem to show any sex disparity. And so, but the other parts, like instrumented lockments, pivots, higher percentage of females having looseness of the graft. The KT1000, which is a more objective measure, they didn't get enough clean data to be able to compare across the 13 studies. And so what you can conclude from this type of research, where it's kind of a large larger populations that there is a trend toward the hamstring graft being more vulnerable among female athletes. And so I think, what I concluded from this is that, just these first set of studies that I kind of show you, is that I do think there is sex differences in terms of rate of re-injury after ACL reconstruction. I think the female risk typically is more contralateral versus, and it's not usually to the graft, but graft choice may impact what happens to that ipsilateral knee. If you had a hamstring graft and you're a girl, you may have more likely to demonstrate laxity clinically. Whether or not that leads to re-rupture, I think the literature hasn't made that connection. It seems to suggest it, but it's far from an established issue. In terms of if you're a male, you are at a higher risk to re-injure that graft that you had surgery on. So, and that might be because you may have a higher activity level, because girls may not all of them may be able to get back to sport or at the same activity level as the the female counterpart. And so I think, for me, those are what we know based on the studies so far, just looking at the clinical research. So I think before I go to the next section, do anybody have any questions? Okay, so now we're going to switch gears a little bit. We're going to talk about sex and how people rate themselves after ACL surgery. So a lot of the things that we've kind of shown so far are things that we measure in people that we pull on, whether it be laxity, hair. These are all observant things that we collect. So this next part is really how patients will rate themselves in terms of how happy and how satisfied they are after their ACL surgery. So I think just in general, what we know from these 3 studies that are listed here is that females in general will report that they don't have as good of outcome after ACL surgery when compared to males. And so we see it in the less than 16-year-olds. We see it when they break it up from 16 to 25, that they just don't, in terms of, if you look at the IKDC score, how they will rate themselves in terms of their SANE score, which is just 0 to 100. Girls in general rate themselves at a lower clip when compared to their male counterpart. And a large systematic review of 35 studies from Scandinavian registries, they noted that men had a better odd than women to get what they consider good functional recovery in KOOS, which is having a pain score that is better than 90, symptom score greater than 84, ADL greater than 91, sport rec. So women just tend to rate themselves lower on these scales in general when compared to their male. They will also say that after ACL surgery that they had less improvement after the surgery than the male counterpart. And in a different systematic review looking at this, they also noted that the female athletes have lower scores when compared to their male counterpart. So I think just in general, females seem to suggest that their outcome after ACL surgery is not as high as males. So this study took it a step further. So they basically, and it's a small study, but I think it is important to get patients' perception of how good they are doing after surgery, because at the end of the day here, the physicians provide one set of bar that we compare ourselves in terms of how good we got somebody, and that's pulling on the knee, that's the laxity, that's the range of motion, that is the return to sport. But how patients kind of rate themselves is also important. But I basically included this study mainly because not only does it say that females were less likely to meet what they considered moderate and vigorous physical activity, which is usually 150 minutes of moderate intensity activity or 75 minutes per week of vigorous activity. So in general, the girls in this particular study, more than 2 years out from ACL surgery, were less likely to achieve that MVPA level But it's also super interesting because they basically made these people wear their accelerometers, and they track their activity level. So people, what their perception of what their baseline activity level were, and what was truly measured, there was actually a discrepancy. And so, I think I included this mainly because even though we focus on what people feel is their activity level, that perception of what they should be doing or are doing may not be really truly reflective of what they're actually doing if you measure that. And so I think I put this mainly as a cautionary tale that even though we focus a lot on patient-reported outcomes in the activity scale, sometimes that may not be an accurate assessment of what they do. So that's now like back up just a little bit and just kind of look at not instead of just how they feel they're doing, how many people just got back to sports. So this is out of Melbourne and La Trobe University. So among their 1,440 athletes, majority of them being male, most of these being hamstring autographs, and these are slightly older patients. What you saw was that a greater proportion of men were actually able to get back to the highest level of activity when compared to women counterpart. And you see these especially in the less than 25-year-old, which is 52% versus 39%. So I wanted to pause just for a second, just for you to kind of think about this. I think that the concept of people always getting back to their pre-injury level after ACL surgery, most of us would think that's fairly high. We see all of our professional athletes have these surgeries, and we think that's an automatic, that they're going to be back on playing. Like, for example, for a football athlete, they're going to be back next year on Sundays playing again. Reality for most individuals, that's far from a guaranteed situation. So even though the males are doing better than females, that's 52% to exactly the same level of what they're doing. I think they get back to sports, but I don't know if they're getting back to the same level of sports. And so this is something that we're starting to learn, that as ACL surgeons, maybe we're not as good as we think we are in terms of getting people back, even in the sex population that does the best, which seems to be the males. I mean, look at some of these numbers for females, only 39%, less than 25, got back to sports at 12 months after the ACL reconstruction, or 18% at 26 to 35 years old. And that's very humbling to know that we may not be as successful as we are here. So that was a 2-year follow-up. This is so that's a 12-month, and this is another 1-year follow-up. Just once again indicating that we may not be as good as we think we are. So only 50% out of this Swedish registry of individuals were able to return to sport at a year. And the men, but just by being a male, you are at 2.58 times more likely to return at a year than females. The other things that predict for you to do better and go back to playing sports is if you had a higher technical score in the beginning, in your age at the time of surgery. And so those are the two things that those are the three things that they've identified. But once again, that means like females in general don't do as well in that Swedish population. So, seen it in the Australian population, we've seen it in the Swedish population, that females don't seem to get back to their same prior level of sports when compared to their male counterpart. And so I think, in terms of that section, just thinking about patient sex, self-reported outcomes, most studies seems to report that females, would rate themselves less in terms of what they're able to achieve after ACL surgery. And that translates over to their ability to get back to sports, where most studies would seem to suggest that female athletes are less likely to get back to their prior level of sports than their male counterpart. And just in general, our abilities to get athletes back to exactly what they were doing before, the same level, same intensity, may not be as successful as what we think conventionally. And so as I transition to this last part, I'm going to try to talk about some of the things that may be the reason why girls may not do as well after ACL surgery. And like when I think about this, and this goes back to what Dr. Lopez kind of mentioned earlier, is the graft laxity. I think that's one part, but I think it's very complicated because I think when I think about this, I think a person's ability to compete and play at the highest level comes so from the head down, really. I mean, psychologically, are there barriers? Are there barriers? When they have surgery, that's traumatic. They have to relearn the leg. They have to go through quite a bit of pain, push through pain to get to the other side. So that whole process builds in some fear. So there's definitely some of that going on. There are differences in addition, besides surgery factors, what we do to them. Girls are made up different, and which we'll talk a little bit about that. They may not have the same muscle endurance. They may be built in ways where they land differently and make them prone to injuries. And then the last part is kind of where I've kind of carved out some things to just kind of understand biologically, do they heal the same? Are female tissues the same as male tissues if we use them for surgery? And intuitively, I think most of us would say, no, I mean, it shouldn't be different. The chromosomes are different. So we would think that there are biological differences, but there's just not a lot of research have looked into that, which is why I think, that's been an area of interest for me. And so this is just looking at people, this is the moon cohort, but they've kind of divided it out to for people that are high school, going back to college or high school football after injury. And this just basically says, like, so these are mostly obviously male athletes, but why do they not go back? And so this is legit, even in high school and also in college. And what you see, number one, is most of it did not go back because a good number of people didn't go back right after the fact that they had other interests or other reasons not to go back is fear. And they identified in their series that nearly a third of their high school and college athletes didn't go back to sports after ACL surgery. And so this is a study just looking at when they looked at all the reasons psychologically why girls don't go back. These are the things that they've identified, and you can see that they have anxiety related to this. Some of it is fear of re-injury. So they identified different studies where there are differences between females and male. When they synthesize this and just kind of think about what may be predictive factors that would make you more likely to go back to sport, just based on looking at psychological components. Being younger definitely helps, but they definitely have identified that the males mentally may be more ready to go back to sport after ACL injury rather than females. And then once again, males are more likely to rate themselves better. And then this next part, which will kind of segue into the next part, is that they're able to demonstrate also better symmetry in terms of when they go through the rehab, the leg, the one that they had surgery on, they are able to do more that looks like the other leg that did not have surgery on. And so I think part of this for me, like understanding this area of the research, is that we train these people really hard physically, but I do think the role of a psychologist, people that have injury, can't be understated, and that maybe that's an area that we need to do a better job on. So in addition to physical rehabilitation, should there be mental rehabilitation, especially in female athletes, to get them to cope with their injury, the surgery, the recovery, so that maybe we can raise their ability to get back to their competitive sports. And so these are just examples of various things that girls may do wrong, especially when you look at these landing patterns, like D, E, and F. These are all very bad injury patterns, and there are multiple studies out there that show that women are less likely to exhibit good landing patterns. They're more likely to commit more errors landing, and that might lead to the risk of not only just injuring like the knee or loosening the graft that they've had on that knee that they had surgery on, but potentially injuring the other knee, because most of the time we land with both legs. We also know that females in general have a larger drop in terms of the quadricep strength between exercises than men. So they exhibit greater fatigue, and when you're fatigued, your form doesn't look good. So there are those sex differences that we know about. And then the last part is just the biologic part. And we all recognize that that there are differences hormonal-wise between women and men. And females definitely have certain hormones like estrogen and relaxin that can affect the homeostasis of the healing ligament, like the ACL graft once you put them in. That might increase your chance of getting laxity and risk of injury, and even healing after injury. And this has been well studied in people. There's been studies that says that females may be at a higher risk of getting ACL injuries around their around their menstrual period because of the high hormone levels circulating through their body. But what's not been studied is whether or not sex does contribute to the healing of the graft after ACL surgery. The only one that has been done up to this point is this study here, and basically this was a pig study. So these were actually pigs that they've done ACL surgery on, and you can see on this study, basically the females, the white bar, that they have greater laxity compared to the male pigs when you pull on the graft, and the graft histology in terms of vascularity is also lower, and that their females are more likely to develop arthritis. And so overall, just based on this one study, and we can't study human grafts like we can do with animal grafts because nobody can really go in, nobody's going to sign up to have you cut out a piece of the graft to study if you're a human. But in general, based on this study, it seems to suggest that female animals that have had surgery, the graft may be structurally inferior compared to the male counterparts at the same time point. And so this is where I've kind of developed some research interests here. And so I have a basic science lab that we've kind of studied here at Missouri. And so we're basically taking tissues from research animals and then and study just looking at the common tissues that we use for ACL surgery. So basically quadricep tendon, hamstring tendon, and patella tendon. And it's super interesting. So we basically take this tissue, we digest it, we take the cells, we stretch them. The cells in this tissue are the ones that are responsible for driving what happens to that tissue, including healing. And so when you look at male and female tissues, and so the male bars are going to be the striped ones, and the female bars are going to be the solid ones. If you look at metabolism, male tissues exhibit higher metabolism. So they're more ramped up and ready to go than female bars, than female tissue. That's for all three graft types. So that's super interesting. So they're more likely to be excitable and replicate and grow. And this part is also kind of interesting when you look at inflammation. So inflammation is good, but inflammation can also be bad. So in this particular inflammation we're looking at, these are prostaglandins. And so prostaglandins, if anybody you guys remember from your science days, are things that result in dilation, and they also result in pain. And so you already know that girls from the clinical studies rate themselves to be not doing as well, potentially because they have more pain, more fear. But the graft tissue that we put in girls, if you look at this study here, girl tissue are more likely to, once you kind of start loading them, meaning put those tissue under stress, create more of these prostaglandins in that tissue. And so I think these are these may be biologic clues why females may have less comparable outcomes when compared to male counterparts. They may hurt more because they make more chemicals in that tissue that might result in pain. It may not do as well because that tissue that we use may not be as metabolically active as male tissues. So, we're doing a lot of study in this area. So hopefully, as we kind of find out some of these biological keys, we may be able to answer some of these questions. So I think in general, I think it is important to consider sex differences in musculoskeletal disease and research. And I do think sex is an important factor in ACL reconstruction outcome, but it's likely not the only factor. I think understanding what negatively or positively impact these things are important so that we can hopefully address this as a comprehensive approach in terms of recovering an individual from surgery, especially if as I've kind of mentioned about the psychological component, because these are things that we can do and surround our athletes with so that we can maybe improve some of our return to sport outcomes and numbers. And I think what this all kind of hits toward, and is the area that I have a lot of interest in, is that if I operate on one person who may be a male and operate on another person who may be a female, the rehabilitation program between those two individuals should not probably be the same. Most of us now just hand out one rehab. You're going to go through this rehab. And then we're going to clearly go to sports about the same time frame. Does that make sense when there's all this biological variability among that exists between person to person? And I think the answer is going to be that to that is probably no. We probably needed to do what is the next wave of medicine, which is precision medicine, where we tailor the treatment recovery based on what that individual brings to us in terms of their biology, the risk factor, and we're going to have to take into account the whole person, not only just the sex, but also what their fear, their psychological component, what their preoperative levels are, and then basically custom craft a recovery program specific to that individual in order to get as optimal outcome as we can. So with that, I'm going to kind of finish my presentation, and I could certainly field any questions if you guys have that. Any questions?
Yeah, I have one question. So when it comes to outcomes after surgery, is there any literature, what are your thoughts on when it comes to knee braces and the knee brace design on affecting that contralateral knee in females or in males too?
Yeah, I think so looking at bracing after ACL surgery, I think most of the studies have showed that they haven't been able to show for sure that bracing at least helps the knee that you had the surgery on. And so I think most of us brace mainly to protect the doctor, make us feel better, that we have something else that maybe makes us feel like, that we got an armor around the knee that we did a reconstruction on. So for most sports, it hasn't shown that bracing has been effective in terms of reducing subsequent injuries. There's only one sport that I know that there is some literature that seems to suggest that it may help protect the graft from becoming loose, and that's downhill skiing. And so for that population, I think there is some retrospective type studies that seems to suggest that if you brace a skier, there's a chance of having graft laxity and graft rupture. The evidence seems to suggest that there's some benefit there. The only other research literature out there that seems to suggest brace may be helpful is collateral ligament injuries, which is separate from ACL injuries. But there's just really not a lot of great firm research out there. So for me personally, I use bracing. I do brace people. I brace them early because a lot of times they don't have the strength to do the rehab. So I brace them so that they can do the rehab with better form. But as they get kind of out further from their recovery, the brace becomes optional. I do brace my girls, especially within high-risk sports. And if you go back to that first slide that I showed you, it's usually soccer. and basketball. Those are the higher risk sports for females. So I do brace them for those. It's not indefinite. I try to brace them out to 2 years, where I know the injury rates are more higher. Research seems to suggest that after 2 years, the risk of re-injury, whether it be the contralateral limb or the same limb, seems to go down dramatically. And so it's not indefinite bracing if I do brace. But the evidence for it is not super clear, at least based on my understanding of the literature. What other questions you guys have?
Hi, Dr. Ma. I have a question. So have you seen any case studies or reports that are different for pregnant women necessarily? I thought your entire lecture was really interesting. Pregnant women obviously have a different hormonal and type and body type after pregnancy. So I was just interested to see if you saw anything regarding that.
Yeah, so so there's been studies that have looked at people that are pregnant and laxity of ligaments. So I do feel like that there's literature for that, but I don't think at least I'm not aware of and the risk of re-injuring a graft that they've had surgery on. I've had actually a couple patients I've had so they've gotten the surgery from me, and then they got pregnant super early on after their surgery, and they seem to recover fine. Yes, so there's anecdotal experience. I haven't seen a rupture in the couple patients I've had once they've had that surgery. The literature have really looked at ACL ruptures in females. I do know that they're just in general more likely to be lax. Ligaments are just loose in general, and that seems to make sense, right? Your body's trying to your relaxin level, your estrogen level is going to be super high because your body's basically saying, I got to get my ligaments loose, especially around your pelvis, to squeeze this kid out. And so I think there are adaptive changes that happen to your body, but I'm definitely maybe not as up to research if ruptures in pregnant females.
Thank you.
Hi, Dr. Ma. Thank you for that talk. I actually have a question on whether or not the literature supports a difference in graft choice options between the two genders. I know it's been shown that using allograft in the older population is better than and so autograft is often used in the younger population. But I wonder between men and women if different graft sites maybe or anything like that to be more effective than others.
So I would say this is super controversial and it's definitely debatable, but basically what I showed you right in the beginning there, I do think there is some suggestion that hamstring grafts in girls may not be the optimal graft. Because I feel like there's enough studies out there that seem to suggest they just get a little looser for sure compared to males. And I think if you had to choose, every one of us would say we want to have a tighter knee than not a tight knee. And so I do feel like there is enough evidence there to at least you should at least plant in somebody's brain that hamstring tissue in a female, especially in a young female, so less than 20, is that the best option? And I because I do feel like there's enough literature out there that seems to suggest that may not be the best graft to use in a girl. That being said, I think some of it, when you're less than 20, you kind of you're a victim of circumstance because especially for kids that are not fully grown, the patella tendon graft is not a good graft option because you can, for girls that are still growing, you can't drill holes across the growth plate and then put a bone across it, which is what the patella tendon graft has. It's got two sockets that has bone on the ends. And so a lot of times people are using hamstrings because that's the most common soft tissue graft you can use and put across there. I'm really interested to see the quadriceps tendon, so I don't do hamstrings anymore. My graft of choice for soft tissue is now quadriceps tendon. And then it'd be interesting to see if quadriceps tendon have a better run at it than girls. But I do feel like, to answer your question, I do think there's some evidence out there for sure that hamstring grafts may not be the best thing for a young girl. I think as you get older, then it's a wash. I don't think the literature shows that very clearly, but in a young female, I don't know if that's the best tissue to use. But it's super debatable. I think, but I do feel like just with my lit review, there's definitely some evidence to show that that might be the optimal graft choice. So.
Thank you.
You're welcome.
Thank you, Dr. Ma, for that very thought-provoking presentation. Just to go a little outside of the specific research you're doing, do you have any generalized advice for us who are applying for residency, fellowship, in the or looking into the orthopedic field, applying for professional schools?
Like, oh, you mean like, so I'm just gonna lump everything in there. Like, so like medical school, residency, fellowship. So that's very like, so it's very wide ranging. I would say, so, having kind of reviewed people's application on all three levels, one, your academics has to be like, most of you guys, like your academics hopefully are spot on. So I do think it is important to have good grades. I think standardized scores are also important. So like making sure that you do that well is good. That being said, I think the differentiator, so assuming that all is the same, and unfortunately, or fortunately, if you're like somebody like me who is training people, a lot of times the people that do medicine or is in orthopedics or in whether it be residency or fellowship, they're already well qualified academically. But what differentiates people then is the things that they do outside of the schoolwork. So my thing for the trainees I have from my medical students and for my undergraduate people is that you got to do the things that will differentiate you. So when they look at this application, everybody's going to have a similar board score, good letters, good good grades. Is that you got to have extracurriculars that's going to set you apart. So when you choose to do extracurriculars, then you need to make those very meaningful and impactful. And so like research is one way, or what you do with your summers is one way to distinguish yourself. And you want to do things that's bulletable on your CV. So Vic is very good at building CVs. So you want to do everything that you can to build a CV that is attractive to the eyes. And so for research, abstracts, presentations, posters, even these talks, right, that you guys give, these are all things that you may think is normal, like everybody has those, but the fact of the matter is it isn't. And so you have to start kind of build a professional CV that makes you stand out. And then hopefully then that gets you into the door, meaning like then you interview, and then and they can ask you about these interesting experiences that you have, and then you impress them with your interview. But I do think what differentiates most people when I see their CV is the extracurriculars. And I think hopefully you guys all exhibit the right things, which is volunteer, sure that you have the health experience, all that stuff. But so the things I'm talking about when I say extracurriculars, I mean like research, papers, abstracts, posters, talks. I mean, I think all those things are the things that most people don't have. But most of you guys are going to exhibit the right behaviors, meaning like good scores, good grades, do the volunteer work. But you need, I think, to distinguish yourself and help you take that next step. I think research is one way. And research comes in different forms. It don't mean like you got to do what I do, which is like cell work and that type of stuff. I'm talking about, being involved in the summer lecture series. Getting posters done and get your name on those things. Getting abstracts done and getting your name on things. I think those are like CVable things that are really like meaningful and impactful. You don't need a lot to distinguish yourself compared to your peers. So making sure that you have those type of things, I think that'll be really helpful. Okay.
Thank you so much. I really appreciate that. And thank you so much for your presentation.
Absolutely. So it's great to see a new, I think every year is a great group. So it's cool to kind of see the new faces. You guys all outside of some, like all you guys in New York, or yes, most part. Vic, maybe?
No, they're all over.
Okay.
I guess if everyone could put on their camera, I could introduce everyone. But you know, Sam's in Kansas City. Oren is here in the New York area. Tiffany is in New Jersey with Dimpy over there at Rutgers. Robert Wood Johnson.
Yeah.
Kira is down in the Virginia area. Lily's attending Binghamton. Are you with us? I know there's a lot of us today.
Yeah.
Megan is down at Hood College. And then Samantha is actually in Kaiser down in Florida.
Okay.
There's a big diversity here. They're
Yeah.
interested in medical school as well as Ruth. Ruth is here in the New York area, but she's in
Yeah.
high school and aspiring to go to college soon. But again, we have a big diversity in interest in regards to physical therapy. I think you met some of the younger kids, even who's interested in engineering. Khalil, who's interested in sports law right now. You know, Kira's very interested in some of the neurological stuff we've been doing and maybe even possibly going further into medical school versus another professional area. Lily, I think, and Megan are also thinking about physical therapy, possibly medical school as well. But again, Oren is our senior on point right now in the 4th year, as well as Sam being our national study coordinator, and Tiffany and Dippy are just fledgling coming on out and ready to make some moves for themselves.
Yeah, and I think, but for most of you guys, I mean, you guys already have a head start. I mean, I think I didn't do anything like this, like when I was at your level. So I mean, I don't think I knew this stuff. And I think just, I mean, and so, the part of it having, you guys and trying to inspire you guys, contributing to this is also for us, I think we should be able to write great letters for you guys, and I think that goes a long way also. But it's also important for us to direct your effort to result in something that can be helpful for you, no matter what your next step is. And so you guys, I mean, for those of you guys that are near me, you should definitely reach out to me, and we can catch up and we'll try to figure out ways I can try to help you develop your career. And it's kind of interesting. So, I mean, this is like a very national enterprise that we got going on here. So, I think it used to be just in New York, but now like everybody's like all over the country. So that's kind of cool. So it's really neat.
Well, thank you again. I think I have to give Dr. Ma the kudos in helping me in the beginning years when we were trying to, I guess, direct what direction we should go in. I guess that's the best way of defining it. And again, without Dr. Ma's help, we wouldn't have been able to make it to the International Olympic Committee and get our papers accepted for the 3rd time within the decade. And let alone, I think Dr. Ma just saw Dr. Allen give us kudos in the private email with the seniors. Our under 19 paper is the first paper in the world on under 19 population involved with rugby sevens and their injury rates. The unique thing about that is that there's going to be opportunities. We can't go to every conference, but Dr. Cantu and Noxe particularly would like for us to maybe take that under 19 paper on tour, particularly with the National Federation of High Schools. So there'll be opportunities, especially for the upcoming medical students, to be involved and maybe go in different directions with that, maybe even speak on our behalves. There's a lot of opportunities that we've been fortunate to offer. I think Dr. Ma can commented on the best, that what we try to do is give you all an opportunity to be involved with what we're doing with our vision. And it's always hard, I think, to explain it all, and maybe even, actually, I apologize, just explain it within 4 or 5 weeks, because what we've created is such an entity now that it's actually a continental, as Richard just said, national effort representing North America, and we're one of maybe 4 or 5 groups that are doing this on the planet, and we're getting the accolades. And again, I can only thank, it's a full team effort, just the way we've been doing, working together with all of you, with Sam, coordinating things. if we don't work together, and I think Lily and Ruth have seen, I think they're the most senior on the call right now that have been with us the longest, seeing how we've gone over years. Each year gets even better. Am I correct, Lily, Ruth? Just it's an amazing thing to see flourish, that a vision of something, and with the right people to believe in what I wanted to do is got us to where we are with Dr. Ma's efforts, as well as with the seniors that Dr. Ma and I have had, our teachers. Any questions for Dr. Ma in the big picture? And again, I think Dr. Ma's offer is genuine when he says if any of you have any questions, to reach out to him.
Yeah, is my
Good.
email on the screen somewhere? I can't tell. Like, probably not, right? Because this is kind of my my screen part. It's part, you probably can't even read it because I don't really don't want my patients calling me. But no, I'm just joking. But it'd be good for me. I mean, I think someone's got my email. I mean, you guys should just reach out to me. I mean, it's my first time meeting a lot of you guys, but like, you guys can more than share my email. Happy to help you guys, like whichever way, or if you have other questions or like suggestions, because I was you at some point, and so it's good. I mean, I think you guys are all, doing things that are things that are interest to me, because that's obviously why I'm, I've worked with Vic for a long time. We've done this research for ever since I was a fellow. So I think whatever I can do to support you guys, I'm happy to do it. I mean, and then whatever questions you have, or if you need advice, I would have died to have somebody give me that advice. I mean, I'm a first generation immigrant here, and my parents never graduated from high school. They didn't even go to high school. So I think if I didn't have mentors along the way, this is not possible. So I think so it's important to have good mentors, and people that help kind of at least pry a door open somewhere, and think that should be the least that we can do for people that help with the research that we do. So I think just so you guys should get my information, and hopefully they send it out, and then whatever I can do to help you, just let me know. Okay. All right.
Thank you very much for that. At this point, I'm going to go ahead and take a picture since all of you guys are here. Say cheese. Alrighty. Thank you so much, Dr. Ma.